Go.
Hi, good morning.
Morning.
My name is Angelica. I'm going to be your nurse today, and I'm going to be conducting a head-to-toe assessment on you. Does that sound okay?
Yep.
Alright, just going to provide some privacy, and while I do some hand hygiene, could you please verify your full name and date of birth? I'm just going to look through this.
So my name is Dylan Gray, and my birthday is January 24th, 2000.
Okay, perfect.
Yeah, gotta get those germs. Yeah.
Can't get any cooties. Okay. So once the 20 seconds is up, I'm just gonna go ahead and raise your bed, and once I do that, I'm gonna have you sit up, okay?
Okay.
Alright, so I'm just going to be raising your bed now to my working height, and you can go ahead and sit up and dangle your feet over the side of the bed. Okay. So the first thing I'm going to be doing is I'm just going to be looking at the patient's head. I see that it is rhomboscephalic, it is bilaterally symmetric. Is it okay if I touch your head? Can you be palpating for any masses, tenderness, or lesions? Does it hurt when I do this?
No.
Okay, don't feel any evidence of masses, tenderness, or lesions. And I'm looking at the patient's hair. I see that it is evenly distributed, it is brown, it is curly, and it has a soft texture. Now I'm looking at the patient's face. I see that it is oval. The features of the face are bilaterally symmetrical, and at rest, the patient has a pleasant expression, and there is no evidence of any tics or involuntary movements at rest. So now I'm just going to be assessing cranial nerve 7. Could you please raise your eyebrows? Could you please frown? Could you wrinkle your forehead? Could you smile with just lips? Could you smile with teeth? Could you please puff your cheeks, purse your lips, and whistle? Thank you. Cranial nerve 7 is intact. Now I'm just going to be assessing the patient's eyes. I see that the outer canthus of the eyes is aligned to the pinna of the ears. The eyebrows are evenly distributed and bilaterally symmetric. I see that the eyelids are intact. There's no evidence of masses, lesions, or drainage. I see that the skin of the eyelids, the color of the skin, is consistent with the rest of the patient's face. And now I'm looking at the patient's eyelashes. I see that they are evenly distributed, they're bilaterally symmetrical, and they curl out and away from the eyes. Now I'm looking at the patient's conjunctiva. I see that it is pink, it is moist, there's no evidence of redness or drainage. I see that the patient's cornea is transparent and smooth. I see that the sclera is white, and the patient's irises are round, brown, and the color is consistent throughout. So the next thing I'm going to be doing is I'm going to be assessing the patient's 6 cardinal fields of gaze. Could you please focus on my finger and follow with just your eyes? Okay. As I'm doing this, I don't see any evidence of nystagmus, and the patient was able to follow my finger through all 6 fields of gaze. The next thing I'm going to be doing is I'm going to be assessing the patient's corneal light reflex. I'm just going to shine this light into the patient's eyes, and I see that the corneal light reflex is bilaterally symmetric in both eyes. The next thing I'm going to be doing is I'm going to be assessing the patient's pupillary response. I'm going to shine the light directly into the patient's eyes, and I see that the pupils react briskly and symmetrically bilaterally. I'm also going to be testing for consensual pupil response. So if it's okay, I'm just going to cover like this, and I'm going to shine the light into your left eye, and to see that the patient's right pupil has reacted symmetrically and briskly to the patient's left eye. And now I'm going to be testing accommodation. Could you please focus on my finger? When the patient focuses on a distant object, I see that the pupils have dilated, and when the patient focuses on a close object, I see that the pupils have constricted. So now I'm going to be assessing the patient's ears. I see that they are bilaterally symmetrical. I'm going to be palpating for masses, nodules, or tenderness. Does it hurt when I do this?
No.
Okay, don't feel any evidence of masses or nodules. Does it hurt when I press here?
No.
Does it hurt when I press back here?
Nope.
Okay. So the next thing I'm going to be doing is I'm going to be assessing your hearing using a whisper test. So I'm just going to be standing behind you. Could I please have you cover your left ear and repeat what I say? Popcorn.
Popcorn.
All right, good. The patient has a negative whisper test and was able to repeat a 2-syllable word whispered approximately 2 feet away. So the next thing I'm going to be doing is I'm going to be performing an otoscopic exam, and the way that I'm going to do that is I'm going to pull up and back on the patient's ear, and I'm going to be coming in with the otoscope, and I'm looking at the patient's ear canal. I see that the color is consistent with the rest of the patient's face. There's no evidence of masses, lesions, or drainage. I see that there is an expected amount of cerumen, and the color and consistency is consistent with the patient's race. Now I'm at the tympanic membrane. I see that it is intact. There's no evidence of tearing or perforations. I see that it is translucent, pearly gray in color, and there is a cone of light at about 5 o'clock because I'm looking in the patient's right ear. So now I'm returning to the patient's face. I see that the nose is midline. I don't see any evidence of masses, but I'm going to palpate for masses and tenderness. Does it hurt when I do this?
No.
I feel no evidence of masses, tenderness, or displacement. Could you please tilt your head back? I'm going to check inside your nose. I don't see any evidence of nodules, masses, lesions, or drainage. I see that the septum is midline. There's no evidence of perforation of the septum. So now I'm looking at the patient's lips. I see that they are symmetric. They are pink in color and they are slightly moist. I see that the skin is intact. There's no evidence of cracking or peeling. And now I'm just going to be inspecting the patient's tonsils. So if it's okay, I'm just going to have you open your mouth. And I'm going to be looking back. All right, I cannot see the tonsils, so I'll rate them 1+. And I'm going to test cranial nerve 10 now. Could you please say ah? Okay, and when the patient does that, I see that the uvula retracts up and back. Thank you. Now I'm just going to be assessing the range of motion of your tongue. So could you please move your tongue side to side? Could you please move it up towards your nose, down towards your chin? Okay, patient has full range of motion of the tongue. Now I will be assessing the patient's neck. I see that the trachea is midline, and I see that the color is consistent with the rest of the patient's body. I'm just going to be testing range of motion. Could you please go back like this? Now down. Now could you please shake your head no, and ear to shoulders. Okay, I see that the patient has full range of motion in the neck, and the patient was able to complete all moves without difficulty. Now I'm just going to be assessing cranial nerve 11. Could you please shrug against resistance? Now turn your head against resistance. Okay, cranial nerve 11 is intact. Now I'm going to be assessing the patient's fingers. I see that the nail of the fingers is intact. There's no evidence of ridges or cracks. I see no evidence of clubbing. The angle is less than 160. The color of the nail bed is pink. And when I press it to assess capillary refill, the capillaries refill in less than 2 seconds. I'm going to assess the trigger of the hand by lightly pinching, and when I release, I see that the skin returns to its original position immediately. Okay, the next thing I'm going to be doing is I'm just going to be checking the patient's radial pulses. So I'm palpating them for a full minute, and I feel that they are bilaterally symmetrical and the rate is irregular and even with about 60 beats per minute. I'm also assessing the patient's respirations at this point. I see no evidence of use of accessory muscles while the patient is breathing. The breaths are even and regular, and I see that the respirations are occurring at about 16 breaths per minute. Okay, so the next thing I'm going to be doing is I'm just going to be assessing the range of motion and strength of your upper extremities. So what I'm going to have you do first is, could you please do this to see the range of motion of your elbows? Now could you please make a box and just with your wrists? Close the box, close it even more. Now open the box and extend. Now could you please do the same thing with just your fingers? Make a box, close the box, open the box, extend the box. Now could you please go like this with your wrists and do this with your fingers? Okay. Now I'm going to be assessing the strength of your upper extremities. But before I do that, I'm just going to mention that the patient did have 5 out of 5. The patient's range of motion was full bilaterally on both the upper limbs. So now I'm going to be assessing the patient's strength. Could you please push towards yourself? And could you please push towards me? Now please push up. Now please push down. Okay, and could you please try to open your fingers against resistance and squeeze my fingers? Okay, patient has 5 out of 5 strength bilaterally. Now I'm just going to be assessing the patient's fine motor skills and coordination of the upper extremities. Could you please touch your nose like this? Okay, can you touch your finger to your nose and then to my finger? Okay, can you please touch your fingers to your thumbs like this? And can you please do this on your thighs rapidly? Okay, patient has full control and coordination over the upper extremities. Okay, the next thing I'm going to be doing is I'm going to be assessing the patient's the thorax. And so I'm just looking at the patient's thorax right now. I see that the width from side to side is about 2 times greater than the width from front to back. And so I'm just going to step around and examine the patient's posterior thorax. I see that it is bilaterally symmetrical. The muscle development is equal on both sides. I see that the shoulders are aligned with the hips, and the color of the skin is consistent with the rest of the patient's body. Now I'm just going to be auscultating the patient's posterior thorax. Could you please breathe in and out as I ask you to? Okay, ready? In and out, in and out, in and out, in and out, in and out. in and out, in and out, in and out. Okay, thank you. Now could you please cross your arms in front of you? I'm just going to be listening to the lateral aspects of your lungs. Before I do that, I will mention that lung sounds were clear throughout the entire posterior thorax. I heard no evidence of adventitious sounds such as wheezing, crackles, or rhonchi. So now I'm just going to be starting here. Please breathe in and out. 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 And please breathe in and out once more. Thank you. Okay, now I'm going to be moving to the patient's anterior thorax. And I'm going to be examining it. I see that the color of the skin is consistent with the rest of the patient's body. It is bilaterally symmetric. I see that the shoulders are aligned with the hips and are already assessed the respirations while I took the radial pulse. So now I'm going to be auscultating the lungs in the anterior thorax using the diaphragm of my stethoscope. Please breathe in and out as I ask you to. Okay, please breathe in and out. 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 And in out. Okay, thank you. Lung sounds were clear throughout, and I did not hear any evidence of any adventitious sounds such as rales, wheezing, or rhonchi. Now I'm just going to be assessing the patient's cardiac landmarks. I see no evidence of visible pulsations, and as I palpate the patient's PMI, I feel no evidence of heaves or thrills. Okay, so now I'm just going to be auscultating the patient's cardiac landmarks, first with the diaphragm of my stethoscope, and then I'll be going over them with the bell. Okay, so first of all, I'm at the aortic valve, which is at the second intercostal space at the right sternal border. I hear S1 and S2. I don't hear any extra heart sounds or splitting. I'm moving over to the pulmonic valve, which is at the left sternal border at the second intercostal space. I hear S1, S2. I don't hear any extra heart sounds or splitting. And now I'm moving down to Erb's point, which is at the third intercostal space at the left sternal border. I don't hear any evidence of heart murmurs. And now I'm moving down to the fourth intercostal space at the tricuspid valve. I hear S1 louder than S2. We don't hear any extra heart sounds or splitting. And now I'm at the mitral valve, which is at the fifth intercostal space, the midclavicular line, and I don't hear any evidence of extra heart sounds or splitting, and I hear S1 louder than S2. So now I will be auscultating with the bell of my stethoscope, following the same points. I'm at the aortic valve, and I'm moving over to the pulmonic valve. I heard S1, S2, no extra heart sounds or splitting. I'm at Erb's point. I don't hear any evidence of murmurs. Now I'm at the tricuspid valve. I hear S1 louder than S2, and I don't hear S3, S4, or any splitting. And now I'm at the mitral valve. I hear S1 louder than S2, and I don't hear any evidence of splitting or extra heart sounds. Okay, so at this point, I'm going to go ahead and have you lie down while I assess your abdomen. So I'm looking at the abdomen. I see that the contour is flat. I don't see any evidence of masses, distension, or unusual vascularities. So the first thing that I'm going to be doing is I'm going to be auscultating your abdomen in all four quadrants, starting with the right lower quadrant and working my way through the other three. I'm going to be doing this with the diaphragm of my stethoscope. So I'm just going to be listening in all four quadrants, and I'm able to hear bowel sounds about every 5 to 30 seconds, and they are characterized by high-pitched, tinkling, and gurgling sounds, and they were present in all four quadrants. The next thing I'm going to be doing is I'm going to be percussing in all four quadrants. I'm starting in the right lower quadrant. I will be percussing 3 times, moving up to the right upper quadrant 4 times because of the liver, moving over and down. I was able to hear sounds of tympany throughout the entire abdomen, except a little bit of dullness near the margin of the liver. So now I'm just going to be lightly palpating, following that same pattern, going through all 4 quadrants. Please tell me, does this hurt at all?
No.
Okay, I'm feeling for any evidence of masses. I don't feel any masses. Patient reported no tenderness. Okay, good. So the next thing I'm going to be doing is I'm just going to be lowering the bed a little bit. All right, thank you. Now you can go ahead and sit up and dangle your legs over the side. I'm just going to be assessing the patient's lower extremities. I see that the color of the skin is consistent with the rest of the patient's body. I see that the hair is evenly distributed. I see no evidence of edema, redness, or unusual vascularities or masses. Now I'm just going to be looking at the patient's nails. I see that the nails are intact. There's no evidence of cracks or ridges. There's no clubbing. I see that the angle of the nail is less than 160, and when I press on the nail, I see that the capillaries refill in less than 2 seconds. So the next thing I'm going to be doing is I'm just going to be assessing the patient's dorsalis pedis pulses, and I'm feeling them, and I feel that they are bilaterally symmetric. The rate and rhythm is even, and now I'm moving behind just to palpate the patient's posterior tibial pulses. I feel that the rate and rhythm is bilaterally even and symmetric. So now I'm just going to be testing the patient's deep tendon reflex. I'm going to be going here. I'm just going to tap, and I see that the patient's deep tendon reflex has a rate of about 2+. So the next thing I'm going to be doing is I'm just going to be assessing the patient's fine motor coordination. Could I please have you rapidly tap your feet? Thank you. Could you please run your heel down your opposite shin? Thank you. And could you please draw a figure 8 with your foot? All right. Patient has full control over the fine motor skills of the lower extremities. But because your butt is already lowered, I'm going to go ahead and have you stand up. All right. And now you can just go ahead and bend over to touch your feet. And I see that your spine is straight. Both sides of the patient's back are bilaterally symmetric. I see no evidence of scoliosis, kyphosis, or lordosis. You can go ahead and stand up. Could you just stand with your feet together, hands by your sides, eyes closed. Okay, patient has a negative Romberg test. You can go ahead and open your eyes because the patient was able to maintain balance while doing that. I'm just going to go ahead and test the range of motion of your spine now. Could you please bend back like this? Now forward. Now could you please go like this, and then side to side. All right, patient's spine has full range of motion. Patient is able to complete all moves without any difficulty. Okay, the next thing I'm going to have you do is I'm just going to assess your gait by having you walk in a straight line to that wall, and then come back walking heel to toe. Okay, thank you. Now I'm just going to have you stand on one foot with your eyes closed, please. All right, go ahead and open your eyes, and now please hop on one foot. Okay, thank you. So the patient's gait was normal. They were able to walk evenly with a bilaterally symmetric opposing arm swing coming both ways, and the patient was able to maintain balance and had good proprioception and cerebellar function. So that concludes our head to toe. You can go ahead and take a seat. And your call light is right here. If you need it, please press it, and I'll be in to help you. Thank you.